So in terms of the benefits, I think there are two. I'm going to answer this in two ways probably. One is from a patient perspective and where the benefits are, and from a practice or NHS perspective. So I think I'll start with the patient benefits, and I think what we're so passionate about with the services that we provide is that this is at last, I think, a much needed kind of additional capacity that focuses on the medicines, particularly the pharmacist role within a clinical setting in primary care. So essentially a lot of the patients that are seen that are in primary care are on long-term conditions. Most of these conditions, the medicines are a key central point, and it struck me, having worked in the health service for a long time, that often there isn't the time and the capacity and the dedicated focus to help patients proactively. I think that's the biggest advantage, that actually patients can be seen proactively, their conditions are managed proactively. So if you take long-term conditions, diabetes, cardiology, we want the pharmacist to proactively case find and support the patients to get the best out of the medicine, tailor those treatments. So actually you're getting really what the long-term plan in the NHS is all about: prevention, proactive care, better patient experience, better clinical outcomes, sometimes with the same treatments, but with that dedicated input. So that's from a patient perspective. And I guess the health system benefits are similar in a way. So those are all good things for the health system. But also from a practice's point of view, what we see is at last there's another member of the team who can handle some of the workload, freeing up the GPs to do other things. So particularly around initially the simplest area that pharmacists will often start will be the repeat prescribing medicines queries. That quickly extends to the long-term conditions management. So as the role grows, they are an equivalent part of the MDT, the multidisciplinary team in primary care. So we had GPs. I'm old enough to remember when practice nurses were introduced, and that was a new thing. Now we expect them. They're ubiquitous, and I think I want to see a time where pharmacists are like that. So as a patient, you could see a nurse, a GP, or a pharmacist, depending on what's needed for you. So spreading that workload, bringing something different, I think that's as much. We're not getting GPs to be pharmacists to be mini GPs. We're getting them to be pharmacists in their own right, alongside the other professions. The biggest thing, which you can kind of see from space now in terms of the changes in the NHS long-term plan, has been this implementation of these additional roles. So the additional roles reimbursement scheme, ARRS, which is now also part of the GP contract. And essentially they're funding a whole raft of roles. So currently there are 12 different roles included, and that includes pharmacists as well as pharmacy technicians. It's not just pharmacists, which is great to see. And so that primary care network gets an allocation funding based on the size of their population. So just that, the way it's going to work is each year the amount of funding is increasing. So it's kind of a staged plan to allow the PCN to gradually grow its workforce. So typically, just to give you some kind of scale on this, by 2024, a PCN of about 50,000 would have roughly £1 million to spend on that list of professionals. So it includes, as I said, pharmacists, the pharmacy technicians, it's got dietitians in there, we've got physiotherapists, social prescribers. There's a whole raft of things that PCNs can choose to fund through that role. I'm really pleased and proud to say that pharmacists are the one that are making the biggest inroads. So as this role has been developed and establishing, many areas that we talk to are looking at just pharmacists coming in. So some areas got 5 or 6, depending on the size. Bigger areas, 20, 40 pharmacists they're looking to put into role across a much bigger geography. Typically, initially, one of the reasons why this role was set up, you have to remember the rationale in the NHS, it was to solve a workforce crisis. So about 5 years ago, the NHS looked at GP workforce crisis. It was really GPs. There's a real shortage of nurses. And at that time, there was a surplus of pharmacists. And they kind of said, right, well, what if we put pharmacists in to alleviate some of the workload? So we've got to remember that still holds true. So I think that's the first thing. We want to be able to show, putting a pharmacist in a PCN or practice frees GPs up to do other things. And so one of the things is how many appointments can we displace? How much GP time can we free up by utilising a pharmacist? That's one. Then there's, the obvious place to look would be around medicines queries, repeat prescribing. That's often where it's at. But that on its own is not enough, because it'll be a dull job from 9 to 5, Monday to Friday, and the rest in evenings and so on, to have pharmacists just doing that. So the next tier, next layer of the cake, if you like, you want to build on top of that, is then getting pharmacists involved in some of the more meaningful clinical work. So already we're seeing amazing work being done by pharmacists leading on things like osteoporosis, diabetes, respiratory, frailty, and some of the more complex medicines reviews within those areas.
When you say leading, could you give me an example of the kind of thing they would be doing?
Yeah, so we're essentially proactively case finding patients who are suboptimally managed, bringing them in and proactively titrating their treatment up, for instance, or addressing adherence issues. It's not just adherence. It is actually saying, right, if you're a person with diabetes, we see that your glucose level is not controlled and you're on product X, we need to change that to product Y, and then prescribing that product. So actively managing diabetes clinics, osteoporosis patients. So I said earlier in the discussion that in the past, without pharmacists, everyone was just too busy to proactively pull those in and manage them. Now, diabetes is a great example, because we all know the evidence is very strong. Do nothing today and pay the price 10 or more years later, and then at that stage we'll throw the kitchen sink at them with every treatment, going, and it's costly and it's not a great outcome for patients. So upstream now, with pharmacists managing proactively, I think that's the next level. If you then look at what's coming, which is really exciting for primary care networks, the role is seen as more of a leadership role. So how, apart from what I do myself as a pharmacist, I'm now a lead pharmacist and working with the clinical director to say, how do we change the pathway in long-term condition, diabetes or whatever. So that's the next phase that we want to see developing with the leaders in the senior pharmacists within this mix.